Hi, everybody. Welcome. Thanks for attending the second gathering of the Healthcare Reinvention Collaborative. We're really excited to see so many people here dedicating time from your busy schedules to participate in our growing commitment to connect, amplify, energize, and support the diverse efforts reshaping healthcare. Our goal for these events and other activities is to move beyond conversations about how to reinvent healthcare towards action. We are creating a space designed to facilitate collaborative action. And as part of that process, we aim to build awareness and foster connection among organizations, initiatives, and people involved in these efforts, highlighting their progress and challenges. And we look to learn from them and build on success, share knowledge and resources, and identify collaborative opportunities that can fuel real transformation and synergy. So today, we're excited to feature two impressive organizations, Medicine Forward and Nurses Transforming Healthcare. Both are grassroots movements led by passionate individuals envisioning a healthier future for all of us. So here's how today's event will proceed. The leaders from these two groups will share their mission, progress, and challenges in 15-minute segments. After that, we'll open the floor for questions and discussion about today's presentations, and we'll invite you to share information about other organizations and initiatives that you may be involved in or are aware of who are also working to reinvent healthcare. Because we may not have enough time to recognize everyone who wants to share or ask questions during the second half of the meeting, we do invite you to include your questions or shares in the chat as well. Denise will moderate that part of the meeting while Paul and I organize the chat topics and those who wish to be recognized to add to the conversation. And we'll also be making a recording of this meeting available on our YouTube channel, and we'll provide that link in an email within the coming weeks. For those who can stay beyond the first hour, we will transition to what we call speed networking. Participants will move into small breakout rooms of 3 or 4 people and be given 7 minutes to connect. And that'll give us time for 3 of those speed networking breakouts during the last 30 minutes for those who can stay. And during that time, we would encourage you to exchange contact information and extend the connection beyond this event. So it's now my pleasure to introduce the first of our presenters today. Dr. Todd Otten is with us today representing Medicine Forward. Medicine Forward is disrupting how doctors organize one relationship at a time with their mission to stand up for what is sacred in medicine, the physician-patient relationship. By focusing on innovative solutions and collaborative efforts, Medicine Forward aims to improve patient outcomes, enhance healthcare delivery, and address the systemic challenges facing the medical community today. With a commitment to bringing together healthcare professionals, patients, and industry experts, they strive to create a more equitable, efficient, and effective healthcare system for all. So, Todd, welcome.
Thanks for having me. It's a pleasure to be here. I'm excited to chat about Medicine Forward, and I know we have a 15-minute clock. I see it up in the corner. So this is about the same as when I was seeing patients, complex congestive heart failure, depressed, can't afford their meds. I figure and I'll document everything as we're going too. I'm just kidding. No, I'm a family physician, practiced for about 20 years before I stepped away, drawn a line in the sand. Many of you have seen this, but this is the book I co-authored with the patient. And essentially this book has turned into a key, which is really how I got involved with Medicine Forward. So enough about me. I'd like to focus on the organization because I think we're at a wonderful time currently. Medicine Forward was founded in 2020 by a handful of physicians, Eric Topol, Emily Silverman, Esther Chu, Brian Dixon, to name a few, and has had just some wonderful endeavors over the years. But in the last year, we've really gained some steam here. We've got about 400 members currently, and it's not just physicians. It is a bunch of like-minded, positive change agents that are assembling to cause, quote unquote, good trouble. Currently, I serve as the Chief Impact Officer. I joke in many circles that makes me the chief troublemaker, probably because I like to stretch boundaries, ask questions, and challenge the status quo. And that's what we're up to within Medicine Forward. So Lonnie and Denise were kind enough to give me a framework for this conversation. So I'm going to work through that. I only have about 37 pages of notes, so we should be able to cram all that into the next 13 minutes and 20 seconds or so. So the first part was purpose. And if you go back to the origin of Medicine Forward, it's really to restore the doctor-patient relationship, that sacred bond that has been eroded over the years, which can be extremely powerful. extremely powerful, especially when it's done well, both ways, in fact. So we're moving beyond that, though. We're at a pivotal time with Medicine Forward where the inclusivity is becoming a key part of this. We realize that physicians can't accomplish all these changes on their own. And even in our core attraction team, it's about a 50-50 split of physicians and non-physicians. And to me, that's amazing. And I think that speaks to the power that is possible with one-to-one, so to speak, of the physician and the non-physician coming together for change. So that's really our purpose. Long term, we're hoping to um, not only organize these change leaders, but accelerate the transformation. Gabe Charbonneau, who's one of the co-founders, who, forgive me for not mentioning you at the start, Gabe, clearly you're a key cog with our organization for sure. But he talks about a federation of change leaders. And that's really our vision long term, is to organize and assemble those key individuals who want to make change going forward. So what's our vision? That's maybe the second part of this. We like to see our effort as a grassroots or ground up change, get that groundswell to not just talking about the problems, but actually moving towards action. I like to say that we are hopefully a magnet for positive disruptors. Key word in there is positive, because you can cause disruption, but if you're not moving in a positive way, you're probably actually creating more problems than solutions, if you will. Again, I talked about inclusivity, and I think the importance there is really the power of the collective. There's only 1 million physicians plus or minus in the United States, but we have 330 million people in this country, of which the vast majority of them have some level of frustration with the current delivery of healthcare. If we can organize those voices and project those in certain directions, we are going to be very noisy and facilitate a lot of change. So amplification is definitely key. And that vision is not only short term with the project that I'm going to share, but really long term. We vision that Medicine Forward isn't going to be the one making all these changes, but in conjunction with what Lonnie and Denise are doing with the Healthcare Reinvention Collaborative, we can connect individuals, right? We can start to get away from the silos that exist, even with the people trying to facilitate change. There are so many wonderful people out there that I've found in the last year with this new part of my life. It's how do we connect those dots? How do we get John and Kathleen and Lonnie and Paul and everybody else on the same page, so that when an initiative pops up, we can accelerate that and make it go quicker, if that makes sense. And actually, I'm dying to have Denise show a slide, because I'm so excited about it, but we're not there yet. Just bear with me. I'll try to say something funny if I can to keep everyone's attention. So strategy, what are we working on currently? There's a handful of things. We've been working on our foundation, our infrastructure. It's gone from essentially just a few key individuals to a wonderful core group with our traction team, of which Denise is on that traction team. Ooh, and there it is. All right. I love it. Can everybody see this graphic here? Somebody give me a thumbs up or a hand, wave a hand. Yes, perfect. What are we showing here? This is one of our short-term strategies. This is an audio documentary called Prescribe Hope. Prescribe Hope was born out of a conversation with Gabe Charbonneau, myself, and Matthew Zachary in New York City at the Burnout Symposium last November. Matthew is a brilliant podcaster and audio documentarian whose previous work was called The Cancer Mavericks, which had over 1 million downloads. Over 1 million sets of ears, plus or minus, listen to his work. And so Matthew was very adamant that we needed to not just be doing advocacy work, but also activation, meaning leading towards actual change. Denise, actually, if you want to scroll down and show the verbiage here, if people want to read this while I'm blathering on, feel free. So this is what Medicine Forward is aspiring to in the very near future, to get this audio documentary funded, which is what you're seeing here, in production and then delivered before the end of the year. And we're not just talking about the problems within healthcare. We want to get safe haven or safe haven types initiatives in all 50 states as soon as possible. What does that mean? That's breaking down those barriers to mental health treatment resources, et cetera, for clinicians, top to bottom, physicians, nurses, nurse practitioners, pharmacists, everybody. Take out those barriers that are in credentialing language so people can get the treatment they need, so we don't have our colleagues dying by suicide. It breaks my heart every time I see another life lost for ridiculous reasons, and that's a big part of my why. So hopefully everybody's had a chance to see this. And here's my shameless plug that if you want to find a way to support us, this is a way to support us. Throw a few dollars at this project. I think it's going to be amazing. And I think it's going to help not just clinicians, but patients too. We think about the negative ripple effects when individuals are burned out and how that affects patients, how that affects colleagues, how that affects administration. We can't have that going on anymore. So I'll get off my soapbox and I'll get back to what I was talking about, which was strategy. So this is our number one short-term strategy. Long-term, we see additional initiatives similar to Prescribe Hope coming from that core nucleus within Medicine Forward, raising funds, et cetera. But going beyond that, we want to be a part of a network of networks, which is why we are thrilled with what Denise and Lonnie are doing with the Healthcare Reinvention Collaborative. It will streamline the opportunity to spread the word about initiatives such as Prescribe Hope. Perhaps people don't want to work on PBM legislation. Perhaps people want to work on prior auth legislation. I'm just one person, but if I can connect the right individuals, if I can connect Paul with the right person, or I'm looking at Deborah up in my window with the right group to get things started, this is how we can make change. Okay, I'm going back to my notes because I went off on my own little tangent. This is where I'm looking at the clock going, all right, Todd, you got 5 minutes. You got to document all this stuff. You got to call the social worker. You got to send the meds in, order all this stuff. Let's go back to what we were doing here. All right. So what are some of the barriers that we have faced? I think with along the lines of a lot of other nonprofits, we have a lot of energy. We have a lot of enthusiasm. Infrastructure and the foundation is so critical. And that's where, particularly as physicians, we need help. Like I know how to treat patients. I know how to write for medications. I stink at clerical stuff. I'm terrible at it. I need help with IT stuff. Our website needs overhaul. And these are the kinds of things that maybe there's somebody out there that wants to do this. And hey, I got a group that's looking for help. Sure, send them my way. We'd love to have it. So that's one barrier. But then, like many of us, it's funding, right? Who's good at grant writing? How do we accelerate fundraising? And so one of the things that we're doing with this Prescribe Hope initiative is we've gamified it a little bit. We've set up some teams for fundraising to try and reach our goal. And so far, it's been kind of fun. Like I was in the lead yesterday with fundraising, probably because I was the one that turned it on and immediately texted a bunch of my friends to donate some money, and many of them did. And then what did Gabe do? Gabe immediately came in with a higher donation, so he took the lead. And so I texted him, "Damn you, Gabe! Why did you do that?" But it makes it fun, right? And it makes you feel like you're doing something good, donating some money to a worthy cause. So those are two of our biggest obstacles to this point. But we're also finding strategies and solutions to overcome that. I do think it's important to maybe go through some of the principles from our website. I think these are key. And I'm not going to dive into these each one because we've got just about 3 minutes left, but I see a lot of value here. So for Medicine Forward, we build on a foundation of well-being and trust. So critical, so often missing in our healthcare space. We stand up for authentic human relationships. I will freely admit I show up to a lot of meetings looking like I just rolled out of bed or I'm wearing my pajamas, but that's just who I am. And if you don't like it, too bad. So there it is. We put humanistic patient care first. Enough said there. Not only do we bring physicians together, but I see us bringing a whole host of positive change agents together, which leads to we claim our power as change agents. Instead of having that learned helplessness together, if we band together correctly, we absolutely can and will be a powerful force. I believe that 100%. And we speak up for health equity. I was just on a call with a young lady in New York City who is doing mental health treatment, and she was lamenting on the struggles that they had. And immediately my mind went to the Healthcare Reinvention Collaborative. It went to Medicine Forward. How can we bring individuals like that into the fold to find other institutions that are having success in the areas that she's struggling and help her out with that instead of reinventing the wheel? Confront challenges with curiosity and innovation. This is a no-brainer to me. We have to think outside of the box. What is going on currently in so many institutions and areas is not working well. We have to think differently. We have to be unafraid to challenge the status quo. And occasionally, if you're with me, that'll be associated with expletives. Just I was in the Navy, you just have to deal with that. And I don't do it on purpose. It's just who I am. And I possibly have told other CEOs where I think they can go and how I think their ideas are. So it is what it is, right? But we can't be afraid, right? Like you tell me like, hey, this is how we've done it for 30 years. And I'm like, well, clearly that's not working because we're spending a ridiculous amount of money and have horrible outcomes. All right. So I think I've covered most of the questions without droning on, and hopefully we added a little bit of levity here. I know there's going to be time for Q&A at the end, but I want to impart this to everybody. I'm doing what I'm doing because I'm sick of the frustrations of my colleagues and patients. And I believe that Medicine Forward and what Denise and Lonnie are doing with the Healthcare Reinvention Collaborative offers hope. And if we get nothing else out of this conversation today, it needs to be hope. Because if we can provide hope to one other person, we can create a ripple effect. And the next thing you know, we've started to move the needle. So with that, I will stop talking and mute myself. Thank you for having me.
Look at that with 30 seconds left. I'm impressed. So let me see if I can change my view here.
We'll
There
claim
we go.
that time.
What was that, John?
We'll claim that time.
You'll claim that time. So now I get an opportunity to spotlight. So let me do that real quick and introduce Kathleen and John with, sorry, I'm trying to do two things at once, and my mind just does not do that well. So let me introduce or give you a brief about Nurses Transforming Healthcare and then hand it over to Kathleen and John. So our next presenters are Kathleen Bartholomew and John Silver, two of the co-founders and leaders of Nurses Transforming Healthcare. NTH is a visionary nonprofit organization with a mission to transform the healthcare system into one focused on wellness and disease prevention. Led by nurses, it advocates for state-based regional health systems that are not only affordable and accessible to all, but which also emphasize respect and equality for all care professionals to practice at their full scope of practice. The organization imagines a future where high-quality care does not come at the expense of financial well-being, and where every individual, regardless of their zip code, can achieve optimal health. So it's my pleasure to hand it over to Kathleen and John and start your clock. Here it goes.
Thank you. Hardest thing for me to do is to have 6 minutes to speak. But I want to begin by echoing what Todd just said. I mean, this organization and this opportunity really gives me hope. And that's why I'm here, because after 20 years as a patient safety expert and a culture expert, the stories and the things I saw, I was hopeless. Nurses Transforming Healthcare, though, is what inspired me and gave me energy again, because I could see a future for healthcare. I could see it working. So the goal of Nurses Transforming Healthcare, founded by John, myself, Leanne Meyer, and Kim Evans, it started about 3 years ago, is to transform healthcare from a business that profits on disease to a service that thrives on wellness. And what do you think that the most frequent comment that we would receive from people is? When we tell them our mission, it's, well, why don't you just solve world hunger while you're at it? I mean, it's just that it's so big, you can't do it. But we're not just a nonprofit. What we are is a social movement, because we want to change healthcare from a business to that has a commodity, to a service. And underlying that is research. Donna Bedian said, structure dictates process, which dictates outcomes. And LinkedIn is filled with the outcomes of burnout and suicide and demoralization and poor care and providers being exhausted and patients not getting the care they deserve. But I think people don't understand is there's a lot of good people trying to change the processes. But what we believe is you got to change the structure. If you have a lollipop factory, it's going to make lollipops. And what people, our healthcare system is perfectly designed to produce more sick people every year. It's actually working well. It's working just how it was designed. So in order to impact change, what we realized is we have to create a new structure. And that was the adapted public utility model. That's the idea that we put forth as a brand new structure. And it's actually not new. Just last year in the New England Journal of Medicine, Catalyst, there was an article about a healthcare utility model that the pharmacy, Civica, did. And what I love the most about this article is that it says that, looking at their tenets, it's about structure, not technology. So how can we put together a structure that keeps Americans well, that really rewards the people who are working in this structure? So one of our pilot projects, we have 3 pillars to educate, and we've given talks across the U.S. and presented at national conventions to advocate with congressmen, which we do constantly, to educate people that there's another way that we can do this, and then to support pilot projects. And our pilot project in Spicewood, Texas, I'd like to take a minute to tell you a little bit about that. With great help from the Meyer Family Charitable Foundation and Helping Hands Ministries, we went to a food bank and put a nurse practitioner and a nurse into the food bank. We assessed the social determinants of health and created a score that added urgency, what we've discovered. And then the nurse practitioner created a care plan for 41 of the people who kept coming through this revolving door. The goal was to change it from a revolving door to an escalator that lifted people up. And how you do that is you address their stressors. You address the social determinants of health, which, by the way, I also learned in Texas, I was asked not to say. It's the non-medical drivers of health, to be politically correct. So it was, I think the thing that I love the most is it's so rewarding. It's so rewarding. I mean, trying to get the nurse to even charge for her time, because there's such a sense of satisfaction that fills your soul, which is the reason we went into healthcare. No doctor, nurse, physical therapist, nobody who comes into healthcare to make money on people being sick. And this is the core of our problem. Our values are not aligned with the structure. So how do you change that? I mean, how do you even start? Well, you look at theory. We know that healthcare is a complex adaptive system. It's so big. That's why people say, what are you going to do? How are you going to do that? Well, you look at the research. How do you impact change in a complex adaptive system? You create a hold-on. You find one part of that system where you can change it and do everything that Todd's doing and many people on this call are doing, and put them in the right place and put them in the same place. So that's why we're having a Flip Your Zip campaign. We're focused on taking one zip code in America. And what if we could take, Prescribe Hope, the Ames model from the University of Washington, the Costa Rica model, Nuka Health in Alaska, and all the wonderful things, mobile clinics, primary care, the essence of which this whole model is what Todd said, the relationship that the provider has with their patients. What if we could reclaim that back again and put that all into one zip code? Denise, could you put the article in the chat?
I did. Yes, it's there.
Okay, I have a little bit more time. So this is called a hold-on in quantum physics. It's basically something complete and in itself that exists within the whole. And how that impacts changes, people get to see a template. So why can't we go into one zip code in America and demonstrate what healthcare would look like as a service? Because right now it feels like, wow, there's a lot of people doing good things, but if we're going to move it to action, what is the strategy for how to change healthcare, in America? And that's where I'd like to bring in the public utility model and John Silver, because when you look at how you're going to build a structure, John looks at, the 7 goals. You look at the goals. What do you want from this? What kind of a lollipop do you want? I want well people. Okay, well, if I want well people, then I have to build a structure that has these components. And that's why I am so thrilled and honored to work with this team, because it gives me hope. It's the first time I saw, oh my gosh, I can really see this working. I can see a community, where health is a public utility and the social determinants of health are actually the infrastructure. They're the infrastructure for the model. And as we make money keeping people healthier, the community gets to decide, because healthcare should be local. Complexity science says that no person, no matter how wise or powerful, can control outcomes from the top. We need to stop and make a local model where the focus is the relationship with the primary caregiver, and we don't just address the social determinants of health. We actually have the resources and give this zip code the autonomy to decide, what do you need in your zip code? John, could you tell everyone how we would do this?
Well, I can try. So I got into healthcare in 74, and after 20 some years, went back, respiratory therapist, nurse, and every other low-level job. Went back to get, my bachelor's and master's. By the time I was done with the bachelor's, I knew that really what we were looking at were political problems, both within nursing and within healthcare. So I did my master's with a health policy focus, went up to 2 internships in Washington, and worked with a rep here in Florida. In 2000, I decided to do a PhD. Well, I actually had a choice, NP or PhD, and I chose poverty as a PhD. So by then I was really intrigued with what's wrong with healthcare and how do we fix this. I'd already been an ER nurse for 5 years. I heard all the stories. I continued for another 5 years into my doctorate as a practicing ER nurse, because it was like this huge research laboratory of people coming in, telling me what their problems were and why they had to see an ER at 8 o'clock at night instead of going to see primaries or specialists. So what I soon realized was that nobody had really put together a cohesive set of goals of what a healthcare system was supposed to do. So I set out kind of attacking this problem, I thought, as a philosopher. And I put everything on the table, including tearing down the whole system and starting over again. So I developed 7 goals that I thought a healthcare system had to have. Some of the things I needed some other expertise in. So when I got to the cost efficiency goal, for example, I stopped for 2 years and went and got an MBA certification from Tulane so I could understand both the micro and macroeconomics to a certain degree. So I got these 7 goals together and I decided, the systems were the problem. It wasn't the individual process. We had HRSA grants and university projects and everything all over the country that were showing results, but they weren't really sustainable to any degree. And then you have to factor in some things with the US. We're a federated republic, so there has to be both federal and state contributions, if you want to think of it that, into the health system. And you really have to avoid the socialism trap because that's a political stake in the heart here in the US. So I set out to study health system designs around the world. I went to 3 continents directly, studied the Argentinian system, studied the German system, and went to Great Britain to study the NHS system twice. Then presented at a conference in UCLA where I met people from all around the Pacific Rim. Had many great days of discussions with people from South Korea to Australia, Japan, New Zealand, all of those countries. So I came back and I put every system design I could see around the world. It was a coherent system design on the table. And I went through them one by one to see which ones met all 7 goals. It turned out none of them did. And the good news is our system design, if you want to call it a system, didn't meet any of the 7 goals. So then I had to kind of rethink things. And I thought, philosophically, the problem we have in our country is we've never really decided or had the discussion of whether healthcare is a right or a privilege. We tend to have 2 camps and, one in each pole, but that's about it. And we've never really had an agreement. And of course, if you think of healthcare as a right, then you're pretty much looking at some kind of federal financing system, single payer, something like that, which is going to involve tax money. If you think of healthcare as a privilege, well, then you have to be willing to step over the dead bodies of other Americans. So I thought, what's in the middle? We had to have had a problem in this country before where we weren't willing to call something a right, but it was too important just to be a commodity. So I went back and studied US history and I found the FDR solution to the electrical problem in the early 20s. Electricity at that time had a lot of the same problems healthcare has now, distribution of resources, a lot of LLCs over these corporations that controlled electrical production. And then a lot of neglect for zones, communities, rural communities, inner city communities that couldn't really afford the rates that they just made up and charged. Sound like healthcare? Yeah. So I looked at the public utility solution that FDR had come up with, and I studied the natural monopoly theory back into England because that's where it came from. So I said, all right, well, and I brought the public utility model forward and put it on the table. And I found out if I changed 2 of the things, if I changed the administrative structure and I gave it a sustainable financing model, that this system design takes healthcare, and not just healthcare, innovative healthcare, right down to the street level in every community. It also opens up the door to things like Kathleen was talking about, addressing the social and economic determinants of health. Well, at least those a healthcare system can design. And since these systems would be integrated with each other, they would, and let me get it. First, it's state-based regional systems that are doing this. I think Kathleen brought that up, but they're no longer competitive. So they can help each other, for example, in disasters. If there's tornadoes 20 miles away, we can mobilize regional healthcare resources in to help there. The regional systems are governed by a council of interdisciplinary providers. And this was the big administrative change I thought had to happen. Because as it stands now, the system goals and the provider goals are asynchronous. And we have to restore that system design to the goals of medicine and nursing and the other healthcare professionals, and most of whom have codes of ethics like we do. And the other advantage of this was that it also included academia, public health, EMS at these tables that decide key issues, for example, distribution of resources, community needs, and then what we can work together to come in to deliver those services to the communities. If you go down the goals, it kind of outlines the evolution of this model.
And John, I'm just going to cue you that 15 is up. If you can wrap up, I hate to leave it hanging, but we'll give you 1 more minute.
Sure. No, thank you very much. Sorry. So the goals are kind of the key. Each one is kind of a little silo. For example, I had to design or come up with a new community assessment tool because I didn't feel the public health ones I looked at were very thorough. And since 90% or more of what we think of as healthcare is actually nursing care that people need, it made sense to use a nursing-based community assessment tool. Well, I'll let you have the goals there. I guess, sorry, my time's up.
Don, you know what I love, and from all three of you, is there's such passion for this work that you're doing, what you've created, what you're doing, and the rationale behind it. So I thank you so much. And I think you both have teased enough that people will reach out and ask for more. So the emails, your LinkedIn URLs, those were added. And I anticipate that you're going to get some outreach. I hate to cut you off, John, but I do want to open it up for some Q&A. So allowing others who have joined us today to ask further questions. And John, that may give you the opportunity to actually give some more insight, because maybe somebody will ask to learn a little bit more about what you're talking about,
Sure.
which would be fabulous. So we'll open it up to questions now. Gabe, I see your hands up.
Yeah, so I'm not turning on my camera because my face is still partly full of food, but John, really great to finally meet you a little bit virtually. And I caught the end of the conversation, but the thing that really struck a chord for me is this question of like, is healthcare a right or a privilege, and what do we do with that? And I think this is one of the places this conversation about transformation gets stuck, is because people can't necessarily agree, or not even enough of us are talking about that. But I've started to wonder if we should expand the question into things like, you brought up basic infrastructure like electricity, and like having conversations about how is this more of an infrastructure problem, and how can we make it clear that it affects everyone when we don't have adequate care for so many people, that it's not about like whether it's a right for me, Gabe, to have medical care, but it's as a society that I'm part of, I suffer as a member of the society if other people don't have care. And so, I mean, it's a personal interest for all of us, aside from a societal and community interest, that it should be. So like, rather than speaking to people about philosophy of whether it's a right or not, let's just talk pure like nuts and bolts of how society works. And I also have been exploring, is it an issue of national security? I mean, what kind of language will get people to take action, right? All right, that's all I got.
Love it.
You're absolutely, it's also a productivity issue in this country. So, and not just to mention the consequences to individual lives and to the despair in communities with so much comorbidities that we see now, and then the inability to access, real advice from healthcare professionals, and not just, what pops up on the internet.
I'd like to talk about the national security issue. The Pentagon did a report, over 77% of applicants for the military in all branches needed waivers, medical waivers. So yes, it's a matter of security too.
After 9/11, for example, over 65% of the people that tried to join the military were rejected for military or for medical.
Yeah, and then 77% needed waivers. Yeah.
Roberta, I see your hand up.
Sure, thank you. I am part of NTH, and I think, John, if you could just give the example that you've given before about how it would be paid for as a public utility. You give the example about the kid who breaks his arm and they get the bill in the mail, and I think that would be instructive to everybody, just to get a better understanding of how this model really works on the ground.
Sure. Well, with the direct experience in the political system, I realized pretty quickly that, with all the money coming in, it can vary from 100 million to 300 million a year coming in from the specialty groups in healthcare, that really the only way to go forward for us was to develop a public media campaign to educate people that there's another alternative. So I designed a series of commercials, and that's where we are at NTH now, is trying to get the funding to get these commercials produced and then put them into some markets around the country. So the commercial she's talking about it's a real easy commercial to do. A man walks out of his house, he's looking at his mail. There's a scream inside, a voice screams, she broke her leg. You see an ambulance, and they're going to the hospital, and they're walking back in their house. And the wife says, how much did that cost us? We're a little short this month. And he talks about the copay and the deductible. And she looks at him and goes, honey, we really can't afford that this month. And then the flip side of that commercial is the exact same scene, exact same thing, up until they're walking back to the house. And she goes, how much did that cost us, honey? We're a little short this month. And he looks down at his utility bill, sees healthcare $50, and he goes, it didn't cost us anything. And I think that's the message we're trying to bring out, is we can easily afford healthcare in this country without having to bill everybody for insurance. So we get rid of the insurance burden on physicians, so they don't have to worry about pre-authorizations. The downside is that you need a very invigorated peer review process for all of us. Thanks for the question.
Yeah, there's a question in the chat from Marlene Seiden asking, can you please describe the current model being tested?
Is in the Spicewood project? Yes, we wanted to see, we knew that looking at the social determinants of health made a difference according to the research, but we wanted to see what a nurse-led model with a holistic picture of each patient would look like. For example, a woman just came in yesterday and all she wanted was money for rent. And what we found out, she hadn't paid her Medicare premium. She didn't have any insurance yet. She had chronic illness. So, we do a holistic picture and realize the most important thing is for her to get to the doctor. And she didn't know she qualified for, the no Medicare, and we address her needs. And it's just wonderful seeing that now she's going to go to the doctor, and, we're going to prevent that chronic disease from going down. We prevent hospital readmissions. We've saved 2 lives. And that's just in our program that's not even been a year old. So, what we learned, and this is what I want to throw out to you and ask for your help with, is that after we look at the money spent and after for the nurse and the nurse practitioner, and we look at all the outcomes, all the Z codes that have been captured, all the Z codes that have been resolved, all the money that has been captured for these people, instead of the church just handing out, they had a ton of resources that they were entitled to that as we know in the country, the resources aren't getting to the right people. So that did that as well. But they're on the Excel spreadsheet. When you look at it, there is no column. If you're going to change healthcare from a business to a service, you need more columns on your spreadsheet. Where's the column for the connection and the relationship that the patient has with their primary care provider? Where's the column for genuine caring that motivates another person because you care about them to care about themselves? Where's the column for increased connection? Because we know that there's social, disconnection, and only 16% of Americans feel connected to their communities. So as you create a new movement, or as we switch this to a service, we need different measures. What do you want to measure? The quality of life index is a good one that is being used. But do we ask that question? Are you happy? Do you actually perceive that your caregiver cares about you? Do you feel cared for? These are important questions when you create a model that is based on service.
I want to clarify one thing. This is not a competition between nursing and medicine. We need everybody working as partners together to address these needs in a very complex geography. I mean, if people often want to compare the model in Germany to the model in the US. Germany is smaller than the state of Montana. We share much more in common with countries like Canada and Australia, and they are struggling with the single payer. We do have an advantage in this country in that we have an army that's not being fully utilized, and that is the 370,000 nurse practitioners that are out there. So we have an advantage other countries do not have to get out and, again, work in partnership with medicine, with pharmacy, with nutritionists, with physical therapists to really bring health into the communities. And then understanding that community health is not just how many diseases are there and how many hospitalizations we can reduce. A healthy community has a sense of optimism, of progress, of being engaged in the community at large. And while healthcare can't solve anything, everything by itself, having some kind of resource in a community allows you to bring in other state resources, for example, that can augment the health of the communities.
And also, we're doing some research at the University of New Hampshire. The students, Emily Spensky at the University of New Hampshire, is doing a needs assessment with her students, trialing the assessment in a community, and going back to the community. So a nurse does a care plan for a patient. And I guess one of the things that we learned in Texas was that people don't know what nurses do. So that was interesting. They thought that we were glorified community health workers, but more expensive. I think that was one of the comments. So not understanding the role of a nurse and how you do a holistic picture and how you do a care plan, that was important.
Keely, I see your hands up.
Thank you, Denise. I have to start by saying I love John. This whole concept. So if it sounds like I'm being trying to be a rabble rouser, I am, but not out of anything but love. My question is that when we look at smaller communities, in my mindset, where we have more of like a tax-based model to pay for healthcare, the taxes are, in line with your income. When we're talking about a utility, often people end up paying more for electricity in proportion to their income than a wealthier person would. How do you, see a solution for that to make it more equitable for people to access?
Sure. Well, again, I go back to the fact that we have no idea how much healthcare actually costs in this country. And there's multiple reasons for that, but if you've ever read, for example, Uwe Reinhardt's work, and you look at how pricing was developed in healthcare, they basically just made all this stuff up. So I'm thinking that, when I looked at my model and we did the economic analysis, we're showing a 42% reduction in healthcare costs in this country, which is a pretty big chunk of money. So we can make individual decisions about progressive up to a certain point, but we don't want to become a money pit. So one of the goals in this utility model I'm talking about is cost efficiency. And so part of that is these regional systems working under a budget. And then they can decide the innovative strategies that they need to reach particularly small communities, which is a very difficult challenge when they're 60, 80 miles away from, metro areas. But I think the solution to that really is nursing innovation. So Kathleen said a lot of people don't understand nursing. We've got over 140-year history of finding people in this country that need help and helping them. Whether it was tenement buildings or rural gullies in West Virginia or small desert communities in Arizona. So this kind of innovative delivery is inherent in nursing. And when you add in the fact that the reason I put nursing as the chair of the regional systems was that we have an ethical obligation and understand that healthcare is not just this patient in this bed, but it's also a broader picture of communities and states and national health. And again, we work as partners to do that. So yeah, there's going to have to be, other economists that come in and say, okay, so this is the budget. How do we arrange that with some kind of progressive level of payment? But whatever it'll be a lot less than everybody's paying now.
And none of us can do this alone. We're so excited to collaborate. That gives me more hope than anything. We need each and every person on this call and your wisdom and your expertise and your input, to make it happen. You believing that everyone has a right to be well. If we believe that and hold that up, and then as Todd was saying, the sacred, what a great word, Todd, the sacred relationship, reclaiming that sacred relationship between the physician and the patient, the nurse and the patient, reclaiming that is really the essence of any new system, because that relationship has been lost.
Leanne, I see your hands up. Please go ahead.
I was just going to say that not only does everybody have the right to be well, we cannot be a well society if we do not have the vast majority of us being well, because those people who are not being treated will be sick. They will spread whatever sickness that they have. So the idea that we don't want to give something like this away, the idea is we need it for everyone to be healthy. We have to have, people taking care of themselves and being taken care of in ways that move us forward to a healthier country. Right now, we're sitting ducks.
I'm actually on the cusp of starting a unique direct primary care model for a very forward-thinking emergency room physician group in Grand Rapids. And for those that aren't familiar with direct primary care, it's more of a direct contract between the clinician, physician, what have you, and your patient group. And you eliminate this whole layer of, pick what colorful adjective you'd like to put in there. I often say fat, that doesn't add value. And I think that could be a key part to a model that John speaks to eliminate a lot of the waste that currently exists in our infrastructure. So stay tuned with that. And I think the corollary to that is, as the person that's going to be leading this charge, I'm going to be looking for best prices for CAT scans and imaging and what have you, and reaching out directly to some of those entities within the area I'm going to be working. So it's a fascinating part of what I think could be a solution to our existing cost issues. So I'll stop on that. Denise, did you have another question?
Well, and you actually queued up what I was going to ask in regards to what Medicine Forward or yourself might be doing similarly to what John and Kathleen are talking about, and how there's correlation or integration to the work that medicine focused efforts might have with nursing. And so direct primary care is one of those that comes to mind.
Well, for sure. And I think, one of the things that we'd like to do within Medicine Forward, and Gabe can piggyback on this too, is, again, we're not going to be the ones to have answers for everything, but we feel like we could be a repository where if we have different individuals that are interested in perhaps direct primary care, point them to other institutions that are doing that, like the DPC Alliance, or I think Docs for Patient Care is another group out there. Right. And you start to get these ideas filtered out to the greater masses, and all of a sudden, all these dollars aren't going to the the bahukas or whatever we call it, the big insurance companies for those that so yeah, that's where I think entities like what the Healthcare Reinvention Collaborative are doing, as well as Medicine Forward are doing, and it marries well nicely with what John's doing.
And Gabe, I see you just dropped that image of the mission for Medicine Forward, which is to stand up for what is sacred in medicine, our relationships with our patients. Thank you for sharing that. So we still have about 6 more minutes. Paul, are there any other questions in the chat that we may have missed?
You know, I don't know that there are questions, but there sure is a lot of commentary and back and forth. There's a lot of content in there.
Yeah. I will share that. Well, I want to open it up then for any of those individuals who have put some commentary. Is there any additional that you would like to say to that? Or are there others who have, are there other organizations who are doing great work that you might want to highlight and help us to help everybody on this call to gain awareness of? What is the call to action I see from Andrea? I think the call to action primarily from this event is join and get to know more about Medicine Forward and Nurses Transforming Healthcare. Michelle, I see your hands up.
Yeah, it's what a fascinating conversation. You're right, both in the conversation and on the chat. So glad to be here. I just wanted to make everyone aware of Medipreneurs, which is an organization that's bringing those who are in healthcare, have been in healthcare, who've jumped and created their own business, who are functioning as entrepreneurs and have so many innovative ideas, coming all together in April in Charlotte. And I'll put the information in the chat, but I just wanted you all to be invited because it's another group trying to solve this almost now from the outside back in as innovators who've been within the system. So again, glad to be here.
Excellent. Gabe and Keely, I don't know whose hand was first, so I'm going to go ladies first. Keely.
Thank you. I think it probably was Gabe, but I'll take it anyway. I just wanted to put my quick little plug in for Health for the People. So these kind of conversations that we're having in this space, I want to be having them day and night whenever the thought strikes you. And the idea of the drawing room, which the link is in the chat there for you, is that we can have these thoughts and we can build on them in real time rather than only being able to meet every couple weeks to have the conversation. And there are 15 solutions that are proposed, but as John knows, they're very flexible. And so the concept is it's a movable thing, and you get in there and you give your opinions and your expertise, and then it shifts over time to a model that really looks like what we want to see moving forward. If that's this utility model, that's great. If it's something that incorporates that and maybe some other components, that's also wonderful.
Solution starters, right? Start those conversations. Gabe, we're going to finish up with you, and then Lonnie will close us out.
Awesome. I'm so excited to see so many people here that are just motivated to have these kinds of talks and interactions. My closing is that what I feel we need is a shared dream, and we're getting closer to that point, but we're not there yet. And I dropped a link in the chat to one of my favorite thinkers, Donella Meadows. She's kind of one of the god founders of systems thinking, and I think for system transformation, incredibly important figure. And this outlines leverage points where you can intervene in a system for change. And the most powerful place is paradigm, which is like kind of the overriding consciousness that the system comes from. So I challenge all of us to think about what is that shared dream that we can come up with, because it's not whether healthcare is a right or a privilege. Like, we don't even all agree about that. It's not about Medicare for all or not. That's not what the shared dream is. But there is a shared dream somewhere in these conversations. And if we can figure out what that is and turn it into a social movement, that is going to be powerful. So that's, I guess, where I want to leave it.
What a beautiful way to do that, Gabe. Thank you. Tawny, or Lonnie, do you want to close us out?
Certainly. This has just been a fantastic conversation. The only frustrating part is that we can't, keep going with it, but we have a format, and we're trying to respect everybody's time. And we want to thank everybody here who's joined us today, particularly our presenters, Dr. Todd Otten, representing Medicine Forward, Gabe Charbonneau, Dr. Charbonneau, who just joined a little bit later, John Silver and Kathleen Bartholomew, and others who are here representing Nurses Transforming Healthcare. And just want to wrap up with just a little bit about HRC, Healthcare Reinvention Collaborative. We're creating a collaborative network by connecting, amplifying, and supporting innovators, change makers, and frankly, ruckus makers, like some of the people who are here, most of the people who are on the call today, to reinvent healthcare. And we're building that momentum really rapidly. So if you want to join us, here are a couple of ways you can do that. First, if you haven't already added your name and email to our mailing list on the HRC website, you can click on the Join Us link at healthcarereinvention.com and add your contact info. So that way you'll receive regular updates about our events, activities, and progress as we continue to grow. And Denise will be, or maybe already has, dropped links in the chat to our website and the Join Us option. Also, if you're interested in getting more involved in the actual creation and evolution of HRC as part of our core builders team, please send us an email, send it to info@healthcarereinvention.com, and we'll definitely be in touch. And just while we're concluding this as our main session, that 1 hour,